Patient's here.
Oh boy, got some blood going.
Yeah, there's never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in emergency
in your left hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. Today, we're wading into what I honestly think is one of the most deceptively difficult topics we have ever covered.
Oh, absolutely. It's a beast.
Yeah, we are talking about the pediatric genitourinary system,
Mm-hmm.
or, as I like to call it, the area where basic plumbing meets really high-level chemistry.
Right, and you have to layer on top of that some incredibly sensitive social development issues.
Exactly. I was looking through our source material for today, specifically the deep dive into nursing care for a child with an alteration in elimination.
It is a massive amount of material.
It really is. I mean, you've got infections, structural defects, where things are literally inside out.
Which is terrifying for parents.
Totally. And then you've got acute kidney failure. It's a lot for anyone to take in.
Yeah.
So our mission today for you listening is to apply the Pareto principle.
The 80-20 rule.
Right. We are going for the 80-20 synthesis. We aren't just going to read a list of diseases from a textbook. We want to identify the 20% of concepts that answer 80% of your exam questions.
And more importantly, the concepts that prevent critical errors at the bedside.
Yes, safe bedside care is the ultimate goal here. So looking at this massive list of conditions, nephrotic syndrome, HUS, hypospadias, VUR, it just feels like a laundry list of random Latin words.
It does, but there is an underlying logic. That's why we mapped out a few master patterns for you.
Yeah, these are like the big buckets that most of these GU problems fall into. If you understand these patterns, you can usually figure out what's going on, even if you blank on the specific details of a disease.
It is all about clinical reasoning. You don't want to rely on rote memorization because under stress, memory fails.
So true. Let's start with pattern 1. You called this the swollen child dichotomy.
Yeah, this is a classic trap, both on exams and in the ER. You have a child who comes in and they are swollen, edematous.
Like puffy eyes in the morning.
Right, periorbital edema. Or maybe the parents say their shoes don't fit suddenly, or they just look heavy.
And the question is always why. From the sources, it seems like in pediatrics, you are almost always choosing between two main conditions here.
Exactly. Nephrotic syndrome or acute post-streptococcal glomerulonephritis.
We usually just call that APSGN because it's a mouthful.
It really is.
But they sound so similar. They both involve the kidneys, and they both cause a kid to swell up.
They do sound similar, but the mechanism behind them, the actual why, is totally different. The risks are different too.
Okay, so break that down for us. What is the decision point? If I'm looking at this swollen kid, what determines which bucket they are in?
It comes down to what is leaking from the kidney and what their blood pressure is doing. So in nephrotic syndrome, I want you to think O for nephrotic and O for protein.
Wait, there's no O in protein.
Well, think of the O in nephrotic. They are losing massive amounts of protein.
Ah, got it. Massive proteinuria. And that makes their urine look weird, right?
Yeah, it makes the urine frothy, like beer foam.
This is a very vivid visual. Frothy equals protein.
Exactly. And because they lose that protein, specifically albumin, they lose the sponge in their blood.
Because albumin holds water inside the blood vessels.
Right. It maintains the oncotic pressure. So if you lose the albumin, the water just leaks out into the tissues.
So they are swollen everywhere.
Yes, anasarca. But here is the key, and this is a huge exam favorite. Because the fluid isn't in the blood vessels anymore.
It's in the tissue.
Right. Because of that, their blood pressure is usually normal or even a little low. They are intravascularly dry.
Okay, so nephrotic syndrome equals frothy urine, massive swelling, but a normal to low blood pressure.
Spot on.
So what about the other one? APSGN.
This is an inflammation problem. Think of it as a clogged filter, not a leaky one.
Clogged with what?
Usually immune complexes from a recent strep infection, they get stuck in the glomerulus.
So like a drain filled with hair.
Gross, but yes.
Yeah.
Very accurate. And because the filter is clogged, they cannot pee out fluid. It stays in the blood vessels.
This means the tank is totally full.
Exactly. And a full tank means high blood pressure. hypertension.
That is a massive distinction.
It really is. The decision point here is also the urine color. It is not frothy. It is tea-colored or cola-colored.
Because of blood.
Yes, hematuria. The inflammation damages the capillaries, so red blood cells leak out, but they get broken down in the process. That's what turns the urine that dark, rusty brown color.
Okay, let's summarize pattern 1 for you listening. If the urine is frothy and the kid is puffy, but has normal BP, it's nephrotic. If the urine is tea-colored and the kid has high blood pressure, it's APSGN.
Exactly. If you see high blood pressure in a GU question, your brain should immediately scream glomerulonephritis or renal failure.
Perfect. Let's look at pattern 2, the plumbing problem.
This one is simple, but it's really critical for safety. Structural defects almost always lead to urinary tract infections.
Because in adults, we usually think of UTIs as, hygiene issues.
Or related to sexual activity. But in pediatrics, the rule of thumb is this. If a newborn or a young infant gets a UTI, it is structurally suspicious until proven otherwise.
Right, because babies shouldn't get UTIs just from sitting in a dirty diaper.
Precisely. If you have a 4-month-old male with a UTI, that is not a hygiene issue. That is likely vesicoretral reflux, or VUR, or maybe an obstruction.
So we treat the infection, but then we have to go looking for the defect.
Right. You have to order the ultrasound or the voiding cystoretrogram to find the why.
A VCUG. We'll get into that procedure later because it's a big one.
Oh, definitely.
Okay, pattern 3 is about surgical timing and safety. You flagged a very specific latex rule.
This is a massive can't-miss safety item. Any child who has frequent bladder interventions.
Like kids with bladder exestrophy or spina bifida.
Exactly. They are exposed to latex catheters constantly right from birth. So they have a huge risk of developing a severe latex allergy.
Is it just the frequency of the exposure?
Yeah, the repeated mucosal exposure sensitizes them very quickly. So clinically, we just treat them as if they are latex allergic from day one.
So latex-free gloves, latex-free catheter.
Latex-free everything. And it's not just in the hospital room. No latex balloons from the gift shop.
Oh, that's a classic NCLEX trap right there. The balloon in the room.
They love testing that.
And under that same surgical umbrella, there's a hard rule about circumcision, right?
Yes. If a baby is born with Hypospadias, which is where the urethral opening isn't at the tip of the penis.
It's on the underside.
Right, the ventral side. If they have that, you do not circumcise them.
Because the surgeon needs the foreskin.
Exactly. They use that tissue to rebuild the urethra later. If you circumcise them, you've essentially thrown away the repair material.
That's a great visual to remember. Don't cut until you've checked the plumbing.
Good rule for life, really.
Yeah. Okay, pattern 4. The pediatric emergency flags.
2 big ones to keep in mind here. First is testicular torsion.
Torsion equals ischemia.
Yes. Time is testicle. You have a very short window, about 6 to 8 hours, to untwist it and save it before the tissue dies. It's an absolute surgical emergency.
And the second emergency.
Hemolytic uremic syndrome.
Yeah.
HUS. This is usually caused by an E. coli infection.
The hamburger disease.
Right. The rule here is incredibly counterintuitive. Do not give antibiotics for the bloody diarrhea.
That just feels so wrong. It's a bacterial infection. Why wouldn't we want to kill it?
I know, but if you kill the bacteria rapidly with antibiotics, they lease. They literally burst open.
And that releases a massive wave of toxins.
Exactly. Shiga toxin. That sudden, massive toxin load is what actually destroys the kidneys. So you actually make the HUS significantly worse by treating the initial infection with antibiotics.
Wow. Okay, so those are our 4 master patterns. The swollen child, the plumbing problem, the latex and surgical rules, and the pediatric emergencies.
Keep those frameworks in mind as we dive into the specific diseases.
Let's start with the foundation, anatomy and physiology. Because, as we always say, kids are not just small adults.
They really aren't, especially their kidneys.
Yeah. From the sources, the most important need to know here is about kidney maturity. A child's kidneys do not actually reach functional maturity until they are about 2 years old.
Which is wild when you think about it.
What does that mean practically at the bedside?
It means they are terrible at concentrating their urine.
Because the loop of Henle is short.
Exactly. An adult kidney can hold on to water if you get dehydrated. An infant's kidney can't do that. It just keeps dumping dilute urine no matter what.
So that puts infants and toddlers at a massively higher risk for severe dehydration.
Huge risk. It also means they don't clear drugs as effectively, so weight-based dosing and monitoring are critical.
And there's a very specific formula for bladder capacity I saw in the notes.
Yes, a general rule of thumb for bladder capacity in ounces is the child's age, in years, +2.
Okay, so if I have a 4-year-old, their bladder capacity is roughly 6 ounces.
Right. And compare that to a newborn.
A newborn holds about 30 mLs, which is just 1 ounce.
Exactly,
Yeah.
1 ounce. That explains why parents are changing diapers basically around the clock. It's essentially a continuous flow system at that age.
And this anatomy piece connects directly to a massive developmental milestone, toilet training.
It really does. You physically cannot toilet train a child until they have the physiological maturity.
The nerve innervation and the actual physical bladder capacity.
Right. Which, again, usually happens around age 2. Before that, if you try to potty train a baby, you are just training the parent to catch the pee.
You aren't training the child to actually hold it.
Exactly. They literally don't have the hardware for it yet.
Let's move to our first major disease cluster based on those patterns, UTI and VUR. We touched on this with the plumbing pattern, but let's go deeper. What is VUR exactly?
Vesicuretral reflex.
Right.
So normally, urine flows from the kidneys, down the ureters, into the bladder, and then out. It's strictly a one-way street.
But in VUR, that one-way valve is broken.
Yes. The valve at the bottom of the ureter is incompetent, so when the bladder muscle contracts to push urine out of the body, some of that urine actually shoots backward up the ureters toward the kidneys.
It's a backwash.
A toxic backwash, yeah. And that backwash carries whatever bacteria is in the bladder right up into the kidneys.
And that's why VUR causes pyelonephritis, kidney infections.
Exactly. And repeated kidney infections cause renal scarring.
And the long-term impact of that scarring is huge. It leads to hypertension and even end-stage kidney disease later in life.
Right. The stakes are very high. We are trying to aggressively save these kidneys for when the child is 40 years old.
So how do we spot a UTI in a kid? Because a baby can't tell you, it burns when I pee.
This is where age-specific presentation is crucial. In a preschooler or a school-age kid, sure, you get the classic dysuria, frequency, urgency, maybe some belly pain or flank pain.
But in an infant,
It is incredibly nonspecific. Fever, lethargy, irritability, poor feeding, they might be vomiting. A neonate might just present with jaundice.
so the exam trap is an infant with a fever of unknown origin.
Yes. If you have an infant with a fever and you can't find a source, no ear infection, no pneumonia, you absolutely have to check the urine. It is a mandatory part of the septic workup.
And how are we getting that urine? I assume we aren't asking a 6-month-old to pee in a sterile cup.
No. And this is where the pediatric nurse has to be the bad guy for a minute. For a diagnostic urine culture, you need a sterile sample.
Because we need to know exactly what bacteria is growing.
Exactly. So in a non-toilet trained child, that means a straight catheterization.
An in-and-out cath.
Yes. It's invasive. The parents absolutely hate it. The baby screams. But sticking a cotton ball in a diaper or using one of those adhesive bags just gives you a contaminated sample.
You could use a bag for a quick screening urinalysis, right?
You can to look for nitrites or leukocytes. But if that's positive and you need to confirm it with a culture to prescribe the right antibiotics, you have to do the straight cath.
Okay, so once we diagnose it, what's the intervention?
Antibiotics are first line, and hydration to flush the system.
And for the VUR part?
VUR is graded from 1 to 5. If it's mild, like grades 1 through 3, we often just monitor them closely. We might put them on a low-dose prophylactic antibiotic.
Because many kids actually outgrow it?
Yeah, as the child grows, the ureters lengthen and the valve often corrects itself.
But if it's severe?
Yeah.
Grade 4
Oh.
and 5?
Or if they keep getting breakthrough infections despite the daily antibiotics, then they might need surgery, a ureteral reimplantation.
Let's talk about the developmental impact of all this. Because having chronic urinary issues has to be incredibly tough for a kid socially.
It's a huge impact. Think about a 7-year-old who was completely potty trained, and suddenly they're wetting their pants at school.
Because of UTI or the bladder spasms from VUR.
Exactly. It's humiliating for them. It causes severe regression. They might start bedwetting again, which is called enuresis. It creates a ton of shame and anxiety.
So what's our nursing action there?
We have to protect their development. We pull the parents aside and reassure the child that this is a medical plumbing issue. It is not their fault. They aren't being bad.
Parent education is a big piece here, too, to prevent bounce backs.
Critical. Wiping front to back for girls is the classic one. No bubble baths.
Why no bubble baths?
The chemicals in the soak severely irritate the urethra and change the flora, making it easier for bacteria to climb up. Also, cotton underwear to let things breathe.
And treating constipation. This is a really interesting link in the source material.
Yes. What does constipation have to do with a UTI? Everything.
Right, because the rectum sits right behind the bladder.
Exactly.
Right.
So a full constipated rectum, we call it a heavy rectal stool burden, it physically pushes forward onto the bladder.
Which prevents the bladder from emptying completely when they pee.
Right. And stasis of urine equals infection. Urine sitting in a warm, dark place will grow bacteria. So an aggressive bowel regimen is actually a core part of UTI prevention.
That is exactly the kind of need-to-know detail that saves a kid from recurrent infections. Okay, let's switch gears and go back to that swollen child pattern.
Nephrotic versus nephritic.
Right. Let's do nephrotic syndrome first. Minimal change disease is the most common type in kids, according to the deep dive notes.
Yes. And remember, our plain language patho here, it's the leaky filter. The glomerular basement membrane in the kidney suddenly becomes highly permeable to protein.
Specifically albumin.
Right.
So the albumin leaves the bloodstream and goes straight into the toilet.
Yes. And we established that albumin acts like a sponge in your blood. It provides the oncotic pressure that holds water inside the blood vessels.
So when you lose the albumin sponge, the water leaks out of the blood and into the interstitial tissues.
Which is why these kids present with such massive edema.
And when you say massive?
We are talking profound periorbital edema. Their eyes might be swollen shut in the morning, ascites in the belly, severe scrotal or labial edema.
An incredible weight gain, right?
Yes, but it's entirely fluid weight. They might gain 20% of their body weight in just a few days.
So if we are looking at an exam question or assessing a patient, what are the top findings for the 80-20 core?
Number 1, massive proteinuria. It'll be +3 or +4 on a urine dipstick. Number 2, hypoalbuminemia, low blood protein. Number 3, the generalized edema.
And number 4 was hyperlipidemia, high cholesterol. That one seems really random to me.
It does seem disconnected, but it's actually the liver trying to help. The liver senses that the blood protein levels are dangerously low, so it kicks into overdrive to synthesize more proteins, but it also turns out a ton of lipids at the same time.
So the high cholesterol is just a side effect of the liver trying to fix the low protein product.
Exactly. It's a compensatory mechanism.
Fascinating. So how do we actually treat the leaky filter?
Corticosteroids. Prednisone is the absolute gold standard here. We hit them with high doses to suppress the immune system, stop the inflammation, and seal that leak.
But high-dose steroids for a kid come with a lot of baggage.
So much baggage. The number one critical complication to monitor for in a child with nephrotic syndrome is infection.
Because of the steroids suppressing their immune system.
Yes, and also because they literally peed out their immunoglobulins during the protein leak. They have zero defense. A simple cold virus can turn into peritonitis or overwhelming sepsis very quickly.
And from a developmental standpoint, steroids are really rough on kids.
Extremely. We see the classic moon face, that round, very puffy facial structure.
For a school-aged child or an adolescent, suddenly looking drastically different like that is devastating for their body image.
They get teased at school, they don't want to see their friends, plus steroids cause severe mood lability.
Roid rage.
Roid rage in a 4-year-old is a real thing. They are irritable, they are starving all the time, they can't sleep.
So as the nurse, you have to do a lot of anticipatory guidance with the parents.
You have to sit them down and say, listen, your sweet, calm child might become an absolute monster for the next few months. It is the medication, it is not your child, and it is temporary.
That conversation probably saves marriages.
It absolutely does.
All right, let's flip the coin to the other swollen child. Acute post-streptococcal glomerulonephritis.
APSGN.
The clogged filter.
So this is an immune complex disease.
Yeah.
The child had strep throat or maybe a skin infection like impetigo about 1 to 3 weeks ago.
Right. The body did what it was supposed to. It made antibodies. It fought off the strep.
But those antibody antigen clumps, they get physically stuck in the kidney filter. Yes, they lodge in the glomerulus. It causes intense inflammation. And because the filter is completely clogged, they can't pee well.
Liguria. Low urine output.
Exactly. And because they aren't peeing, all that fluid just backs up and stays in the bloodstream. Hypervolemia.
Which leads to our number one critical assessment priority for APSGN.
Hypertension.
How dangerous are we talking with this blood pressure?
It can be severe enough to cause hypertensive encephalopathy.
Which means seizures.
Yes. So if you have a kid with APSGN who suddenly complains of a really bad headache or fuzzy vision or dizziness, That is a massive red flag. You need to check their blood pressure immediately.
And the urine color here is our other big distinguishing factor, right?
Yes. It's not frothy like nephrotic. It is tea-colored or cola-colored, gross hematuria.
Because the inflammation damages the capillaries so much that red blood cells squeeze out.
And as they squeeze through that inflamed filter, they get broken down. That breakdown is what turns the urine that dark brown color.
So what's the treatment? Do we give steroids here too?
No, because it's not a leaky membrane we need to seal. There's no magic pill to dissolve the clog. The body just has to clear it over time.
So it's all supportive care.
Strictly supportive. We manage the blood pressure very aggressively with antihypertensives, things like hydralazine or nifedipine.
And we restrict their fluids and their salt intake so we don't add to the fluid overload.
Exactly. And we monitor them closely for those neurological changes that would signal a seizure.
Developmentally, I saw that bed rest is often required during the acute phase of APS-GN.
Yeah, especially when that blood pressure is sky high, we want them resting quietly.
But try telling an energetic 5-year-old that they have to stay in bed all day when they really don't feel that sick anymore.
It is a constant battle. This is where nursing creativity comes in. You need heavy distraction techniques. Quiet play, coloring books, puzzles. And yes, this is a time when unlimited screen time is perfectly acceptable.
Let the iPad do the heavy lifting.
Exactly.
Okay, moving on to one of the scariest acronyms in all of pediatrics. HUS, hemolytic uremic syndrome.
This is the dangerous sequel to the hamburger disease.
It's usually caused by E. coli 0157 HH7, right? Often from undercooked ground beef, unpasteurized apple cider, or trips to a petting zoo.
Petting zoos are a classic board question set up for HUS.
It sounds like the setup to a horror movie. What is the triad we absolutely have to memorize for this?
3 things. 1, hemolytic anemia. 2, thrombocytopenia. And 3, acute kidney injury.
Break down that patho for us in really plain English. How does eating a bad burger cause all 3 of those things to happen?
Okay, so you ingest the bacteria. The bacteria sets up shop in your gut and releases a very potent toxin.
Shiga toxin.
Right. That toxin enters the bloodstream and attacks the endothelial lining of the small blood vessels, specifically the tiny vessels inside the kidneys.
Damages the vessel walls.
Yes, and the body tries to fix that damage by sending platelets to plug the holes. So you get thousands of these tiny little microclots forming all over the kidney vessels.
And because the body's using up all its platelets to make these tiny clots, the platelet count drops.
Boom! Thrombocytopenia.
Okay, that's one.
Then your red blood cells are circulating. They try to squeeze through these narrow, clot-filled kidney vessels.
And they get shredded on the clots.
Like slicing a water balloon through a cheese grater. They are mechanically destroyed. That is the hemolytic anemia. Hemolysis literally means breaking blood.
That is a terrifyingly clear image. And then the third part, the AKI.
Well, because the kidney vessels are completely clogged with all these tiny clots and shredded red blood cell debris, blood flow stops, the nephrons die, the kidneys shut down, acute kidney injury.
Wow. And the critical intervention here, the need-to-know safety point, is what we talked about in the patterns. What do we absolutely avoid doing?
You do not give antibiotics for the initial bloody diarrhea.
Because killing the bacteria releases a massive wave of that Shiga toxin all at once, which just accelerates the vessel damage.
Exactly. It throws gas on the fire. You also do not give antimotility drugs like Imodium.
Why not? If they have severe diarrhea, shouldn't we stop it?
No, you want that diarrhea to get the bacteria out of the gut. If you freeze the gut with Imodium, the bacteria just sit there multiplying and pumping more toxin into the blood.
So again, it's mostly supportive care.
Very intense supportive care. Many of these kids require temporary hemodialysis to let the kidneys rest and clear the toxins.
And they probably need blood transfusions for that severe anemia.
Yes. Packed red blood cells. And strict seizure precautions because the profound electrolyte shifts from the kidney failure can easily irritate the brain.
Let's talk about the developmental impact of HUS.
It is deeply traumatic for the child and the family. It happens so suddenly. One day they're at a petting zoo. 3 days later, they are on dialysis in the ICU.
And because it's fundamentally a foodborne illness, I imagine it creates major psychological issues around eating.
Massive issues. If a child ends up on dialysis, their diet becomes incredibly restricted. Low sodium, low potassium, low phosphorus.
Which means no bananas, no potatoes, no dairy, no processed foods.
Right. For a toddler who is naturally in that picky eating phase where they only want mac and cheese and hot dogs, this new diet becomes an absolute battleground. It is incredibly stressful for the parents.
Let's shift gears from the chemistry of the kidneys back to the physical plumbing structures. Bladder exstrophy.
This is a major structural defect.
This is the one where the baby is born with the bladder completely outside the body, right?
Yes, it is literally inside out and exposed flat on the lower abdomen. It's a failure of the abdominal wall to fuse during fetal development.
So when the baby is born, you just see this bright red, moist mucosal tissue sitting on their stomach.
Yes.
What is the immediate day one nursing priority in the delivery room?
You have to protect that mucosa. You cover the exposed bladder with sterile plastic wrap or a specialized non-adherent dressing.
Why plastic wrap?
Because you have to keep it perfectly moist. You do not want it to dry out, and you don't want it to stick to a regular gauze pad. If that delicate tissue dries out, it cracks, it bleeds, and it gets infected instantly.
And we mentioned the strict latex rule for these kids earlier.
Mandatory latex avoidance from the second they are born. They're going to have multiple massive reconstructive surgeries. Their exposure risk is just too high.
What about the post-op care once they start doing those reconstructions?
He will have catheters, stents, suprapubic tubes everywhere. A major issue post-op is bladder spasms.
Because the bladder muscle is angry that it got cut and sewn back together?
Exactly. And those spasms are excruciatingly painful. What's worse is that a strong spasm can actually pop the delicate surgical stitches or push a stent right out.
So how do we prevent that?
We give them oxybutynin. It's an antispasmodic medication. We'll cover the details in the med module, but it basically paralyzes that smooth muscle so it can heal.
Let's touch on hypospadias next. This is much more common than exstrophy.
Very common. It's the ventral placement of the urethral meatus. The hole is on the underside of the penile shaft instead of right at the tip.
And again, the golden rule. No circumcision in the newborn nursery.
Save the foreskin for the urologist to use for the reconstruction.
When do they usually do that surgery?
Usually around 6 to 12 months of age.
Is there a developmental reason for picking that specific window?
Absolutely. We want to complete the reconstruction before the child's window of body image awareness really opens up.
Castration anxiety is a real psychological phase, right?
It was. Around age 2 or 3, they become very protective of their genitals. Surgery then is much more psychologically traumatic. Plus, you absolutely want this fixed before you attempt toilet training.
Right, because you can't potty train a little boy who has to sit down to pee if all his friends are standing, or if his urinary stream shoots off at a strange downward angle.
It sets them up for failure and shame.
Now, there is a very specific, almost strange nursing procedure for these babies post-op, double-diapering. Can you explain that to a listener who has never seen it done?
It sounds weird, but it's brilliant. It is exactly what it sounds like. You have a baby who just had urethral surgery. They have a delicate little stent coming out of their penis to keep the new urethra open while it heals.
Okay.
You absolutely have to keep stool away from that stent to prevent a catastrophic infection.
So how does double diapering do that?
You take a small diaper, like a preemie or newborn size. You cut a hole in the front of it.
Okay.
You put that small diaper on the baby, but you gently pull the penis and the stent through that hole so they're resting on the outside of the diaper.
So the penis is completely separated from the area where the baby poops.
Exactly. That inner diaper catches all the stool. Then you take a much larger diaper, maybe size 2, and you put it on over the whole thing.
And that outer, larger diaper catches the urine draining from the stent.
Right. It isolates the feces from the surgical site.
Yeah.
It is a brilliant, low-tech way to prevent infection.
That is so smart. Okay, let's jump into the scrotal and reproductive disorders. We talked about testicular torsion being a massive emergency.
Sudden, severe, unilateral scrotal pain, usually accompanied by nausea and vomiting.
And if you assess them, the affected side of the scrotum might be elevated and swollen. But the absolute key sign you mentioned was the absence of the cremasteric reflex.
Yes, that is the diagnostic hallmark on a physical exam.
Remind everyone what that reflex is.
Normally, if you take your finger or a tongue depressor and lightly stroke the inside of the patient's upper thigh, the testicle on that same side will physically pull upward.
It's a protective reflex against cold or trauma.
Right. But in torsion, the spermatic cord is twisted so tightly that the testicle is essentially locked in place. It cannot pull up. The reflex is absent.
And we have a very strict time limit here.
6 to 8 hours maximum from the onset of pain before the testicle suffers irreversible necrosis and dies.
So this kid needs to be NPO immediately, and you are prepping them for the OR.
Don't wait for an ultrasound if the clinical picture is obvious. Time is testicle.
What about cryptorchidism? Undescended testicles.
Much less of an acute emergency, but it has huge long-term implications. Normally, testicles drop into the scrotum before birth or shortly after.
What if they don't?
If they haven't ascended by 12 months of age, we go in surgically and bring them down. That procedure is called an orchiopexy.
Why can't we just leave them up in the abdomen? Do they really need to be in the scrotum?
They absolutely do. The internal body temperature of the abdomen is simply too high. Testicles need to be slightly cooler than core body temperature to function properly.
So the heat damages them.
Yes. Long-term exposure to that core heat causes permanent infertility. It destroys the sperm-producing cells.
Wow.
And even worse, an undescended testicle has a significantly, dramatically higher risk of developing testicular cancer later in life.
So we bring them down to keep them cool, preserve fertility, and lower the cancer risk.
Exactly.
What about phimosis and paraphimosis? I always get these two confused.
You aren't the only one. Phimosis is simply a tight foreskin that cannot be pulled back.
Which is actually completely normal in newborns and infants, right?
Yes, physiological phimosis is normal. You never, ever forcefully retract a baby's foreskin. It will tear and scar. It naturally loosens over several years.
Okay, so that's phimosis. What is paraphimosis?
Paraphimosis is a medical emergency. This is when the foreskin has been pulled back behind the head of the penis, but then it gets stuck there. It can't be pulled back forward.
So it acts like a rubber band.
Exactly. It creates a tourniquet effect. It cuts off the venous blood flow. The head of the penis swells massively. And if it isn't reduced quickly, you get ischemia.
Ouch. So phimosis is tight, but usually normal. Paraphimosis is stuck and an emergency.
Perfect summary.
Okay, let's talk about the end game for all these kidney issues if things go wrong. Renal failure. Let's start with AKI, acute kidney injury.
In pediatrics, the vast majority of AKI is what we call pre-renal.
Meaning the problem is happening before the blood even gets to the kidney.
Right. The kidney itself is perfectly healthy, but it is starving because it's not getting enough blood flow.
And what's the #1 cause of that in kids?
Severe dehydration, usually from a bad case of gastroenteritis. The stomach bug.
So a kid who has been throwing up for 3 days is at risk for acute kidney injury.
Absolutely. Because their intravascular volume is so depleted, the blood pressure drops and the kidneys stop filtering. If they stop peeing oliguria and their BUN and creatinine start shooting up, that is pre-renal AKI.
So the priority intervention is pretty straightforward then.
Fluid resuscitation.
Yeah.
Fill the tank. Give them IV normal saline boluses to restore that perfusion pressure to the kidneys.
What is the most dangerous electrolyte imbalance we need to watch for while their kidneys are shut down?
Hyperkalemia. High potassium, because the kidneys are the only way the body gets rid of excess potassium.
And high potassium is a cardiac killer.
Yes. It stops the heart. If you see a potassium level of 6.5 or 7 on the lab report, you need to act immediately.
What are the clinical signs of that before the heart stops?
Weak pulse, severe muscle cramps, and eventually cardiac arrhythmias on the monitor. Peaked T waves are the classic early sign.
Okay, moving from acute to chronic. End-stage kidney disease, or ESKD. The focus here shifts from quick fixes to lifetime management.
Yes. The kidneys are permanently failing.
What are the big developmental hits for a child with ESKD?
The most profound impact is on their physical growth.
Because kidneys do more than just filter pee.
Right. They are actually vital endocrine glands. The kidneys produce a hormone called erythropoietin, which tells the bone marrow to make red blood cells.
So kids with ESKD are chronically severely anemic.
Yes, they are exhausted all the time. The kidneys also activate vitamin D, which is essential for absorbing calcium and building strong bones.
So without that active vitamin D, their bones become weak.
They develop a condition called renal osteodystrophy or renal rickets. Their bones literally demineralize.
So between the anemia and the bone disease, they just stop growing.
They fall completely off the growth chart. They end up profoundly short in stature, and their puberty is severely delayed.
How do we treat that?
Aggressively. We give them synthetic erythropoietin injections to fix the anemia. We give them active vitamin D, and we often have to give them daily human growth hormone injections just to try and keep them somewhat near the normal growth curve.
That is a massive medical burden for a child. And then there's dialysis.
Right. To keep them alive until they can get a kidney transplant, they need dialysis. But in pediatrics, we strongly prefer peritoneal dialysis over hemodialysis whenever possible.
Why is PD better for kids?
Because of the developmental and psychosocial impact.
Hemodialysis requires them to go to a clinic, right?
Yes, 3 or 4 days a week for 3 to 4 hours at a time. They are hooked up to a massive machine. It makes them feel very sick, washed out, and most importantly, it severely interferes with their ability to attend school.
They miss out on being a normal kid.
Exactly. They lose their friends, they fall behind academically.
And peritoneal dialysis avoids that.
Peritoneal dialysis can usually be done at home by the parents overnight while the child is sleeping.
Oh, wow. The machine just cycles the fluid in and out of their abdominal cavity while they are in bed.
Right. So during the day, they're disconnected. They can go to school, play with their friends, and have a relatively normal social life. It gives them back their independence.
That makes total sense. But PD must have its own risks.
The biggest one is peritonitis, infection of the peritoneal cavity. The parents have to be absolutely meticulous with their sterile technique when they connect and disconnect the bags.
How do they know if there's an infection?
The classic sign is the effluent. The dialysate fluid that drains out of the belly into the waste bag should be clear, like light urine. If it looks cloudy, like someone poured milk into it, that is peritonitis.
Cloudy effluent means go straight to the hospital.
Do not pass go. They need IV antibiotics immediately.
Okay, we have covered a massive amount of disease patho. Let's do the medication module.
This is where we cross-reference everything. Let's do it.
I am going to throw a drug name at you from our source list. I want you to give me the rapid-fire need-to-know, the mechanism of action, and most importantly, the pediatric-specific pearl.
Ready.
First up, desmopressin, DDAVP.
Okay, class is synthetic antidiuretic hormone, ADH.
What's the main pediatric indication?
Nocturnal enuresis, severe bedwetting.
How does it work?
It acts directly on the kidneys, telling them to reabsorb water and concentrate the urine, which significantly reduces the volume of urine produced overnight.
In the pediatric pearl, the big safety warning.
You must treat DDAVP almost like a strict do not drink order.
Why?
Because the medication is telling the kidneys to hold on to all the water. If you give a kid this nasal spray at bedtime and then they chug a massive liter of water or Gatorade, their body will retain every drop of it.
Which leads to fluid overload.
Worse, it leads to water intoxication and severe hyponatremia. The sodium in their blood gets diluted so much that it causes cerebral edema and seizures.
So the parent education is absolutely crucial here. Give the med at bedtime and strictly restrict fluids after dinner.
Yes.
Next med, oxybutynin, brand name Ditrovan.
Class is anticholinergic and antispasmodic.
We talked about this one for bladder spasms after hypospadias or extastrophe surgery.
Right, or for kids with a neurogenic bladder from spina bifida.
The mechanism of action.
It relaxes the smooth muscle of the detrusor, the bladder wall, stopping the spasms.
And what's the pediatric pearl we need to look out for?
Anticholinergics dry you out. The classic adult phrase is can't see, can't pee, can't spit, can't stool.
But how does that affect a child differently?
The big pediatric safety risk is heat intolerance. Oxybutynin severely impairs the body's ability to sweat.
Oh, wow.
So if a child is on this medication and they are running around on a hot playground in the middle of July, they cannot cool themselves down. They can overheat and develop heat stroke very rapidly.
That is a great safety point. What about the can't stool part?
Constipation is a huge side effect. And remember our plumbing loop. Constipation leads to urinary stasis, which leads to UTIs. So if they get constipated from the oxybutynin, it defeats the whole purpose.
So they need to be on a bowel regimen while taking it.
Yes.
All right, third medication, corticosteroids, specifically prednisone.
Indication is nephrotic syndrome. We use high doses to induce remission and stop the massive protein leak.
We talked about the side effects, the moon face, the roid rage.
Oh.
What is the critical safety pearl for the exam?
Infection risk is huge, obviously, but the biggest one is that it completely masks the normal signs of infection.
Because it suppresses the inflammatory response.
Exactly. A child on high-dose steroids could have a raging, life-threatening infection, but they will not mount a fever. You cannot rely on a thermometer. You have to look for subtle signs like lethargy or behavior changes.
And there's a hard rule about stopping the medication, right?
And never, ever stop prednisone abruptly. It causes an acute adrenal crisis.
Because the body's own adrenal glands have essentially gone to sleep while taking the pills.
Right. You have to taper the dose down very slowly over rinse to wake the adrenal glands back up so they start making their own cortisol again.
Next on the list, intravenous albumin.
Indication is severe refractory edema, usually in nephrotic syndrome.
Mechanism of action.
It massively increases the intravascular oncotic pressure. It acts like a giant super sponge.
So it rapidly pulls all that third space fluid out of the puffy tissues and sucks it right back into the blood vessels?
Yes.
and the pediatric pearl.
You have to monitor them incredibly closely during the infusion because you can easily overload their small hearts.
Because you are pulling so much volume into the vascular space so quickly.
Exactly. You watch for signs of sudden fluid overload, pulmonary edema. If they start coughing, if you hear crackles in their lungs, or if they have sudden respiratory distress, you stop the infusion.
And this leads right into our final medication, furosemide or Lasix.
The classic loop diuretic.
Indication is fluid overload, like an APS-GN, or to help clear the edema in nephrotic syndrome.
Right. And there's a specific double-hit protocol we use in nephrotic syndrome. We usually give the IV albumin first.
To pull all water from the tissues into the blood vessels.
Exactly. And then, once the water is in the blood, we hit them with a dose of 5B Lasix.
To force the kidneys to pee all that extra fluid out.
It is a highly coordinated sequential attack on the edema.
What are the safety pearls for Lasix in kids?
It is severely potassium wasting. You must monitor for hypokalemia, look for muscle weakness, or leg cramps.
So they might need a potassium supplement or a diet high in bananas and leafy greens.
Yes. And the second major safety point is ototoxicity.
Hearing loss.
Yes. If you push IV Lasix too fast into a small child's vein, it can cause permanent damage to the 8th cranial nerve. You must push it very slowly.
Okay, this has been an absolutely massive synthesis. Let's try to bring it all together in a final cross-linking summary.
We can really see how all these disparate diseases connect now.
Right, like the structural infection loop.
If you have a plumbing problem like VUR or an obstruction, you get urinary stasis.
Stasis leads to UTIs.
UTIs cause pyelonephritis and renal scarring.
And scarring leads to hypertension and chronic kidney disease later in life. So the overarching goal is to fix the structural plumbing early to save the kidney tissue.
Perfect. Then there's the nephrotic management loop.
You start with a leaky filter, which causes massive edema.
You use IV albumin to pull the fluid back into the vessels and Lasix to pee it out.
While simultaneously giving high-dose steroids to plug the leak in the filter.
But those steroids create a massive infection risk. It's an incredibly delicate physiological balancing act.
And finally, the growth and development loop.
Any chronic kidney issue, like ESKD, means the child lacks erythropoietin and active vitamin D.
Which causes severe anemia and bone demineralization, leading to stunted growth.
So you absolutely must treat the growth and nutrition deficits aggressively with hormones to protect their developmental trajectory.
It all connects. The physical plumbing dictates the chemistry, and the chemistry directly dictates the child's growth and development.
Exactly. That is the holistic pediatric view.
Okay, we are coming to the end of our deep dive. We have covered the swollen child, the plumbing emergencies, the kidney failures, and the meds that fix them all.
We really have covered a lot of ground today.
But before we sign off, I want to leave everyone listening with a final, more provocative thought.
I love these. Let's hear it.
We just spent an hour talking deeply about pee, anatomy, catheters, and bowel regimens. But I want you to step back and imagine being an 8-year-old child going through this.
That is a tough age.
It's the age of deep modesty. You are just becoming truly aware of your body and your privacy. And suddenly, your most private parts are the subject of daily medical rounds.
10 different strangers coming in to inspect your surgical sites.
Exactly. Constant inspections, invasive catheters, multiple reconstructive surgeries.
It is a profound loss of control.
It is. Medical trauma isn't just about physical pain. It is often about a severe loss of dignity. So my thought for you to take into your next clinical shift is this. How do we, as healthcare providers, intentionally protect that child's dignity in a hospital system that is designed purely for clinical efficiency?
That is a great question. Are we exposing them unnecessarily during an exam?
Right.
Yeah.
Are we explaining what we are going to do to them, using words they understand, or are we just talking over their heads to the parents while we prep the catheter tray?
The clinical skill of preserving privacy is just as important as the actual physical skill of placing the catheter.
I really believe that. Treat the whole child. Protect their mind, not just their bladder.
That is a very powerful place to end.
Thanks for taking this deep dive with us today. Keep those master patterns in your head for the exam. Frothy versus tea-colored. Torsion is time. No antibiotics for HUS.
You guys got this.
See you on the next deep dive.
Bye, everyone.